In present, recent advances in molecular biology, including Human Genome Project, has allowed the introduction of targeted treatment for cancer. So finally, we have somehow connected with each other. So मैं थोड़ा सा पीछे नटशल बताऊंगा कि मैंने आपको क्या पहले पढ़ाया था. हेड एंड नेक कैंसर में कीमोथेरेपीज का जो रोल है, कन्वेंशनल कीमोथेरेपीज का, वो तीन तरह है. न्यू एडजुवेंट का मतलब है कि जो ट्रीटमेंट से पहले, किसी भी सर्जरी से पहले या रेडिएशन से पहले. कनकमिटेंट का मतलब है जो रेडिएशन के साथ देना है. और एडजुवेंट का मतलब है जो सर्जरी या रेडिएशन के बाद कीमो देनी है. तो उनमें ट्रायल्स में पता चला है कि इनमें अगर आप कीमोथेरेपी पहले, साथ में और बाद में देते हो तो उनका सर्वाइवल बेनिफिट है. बट ये था कन्वेंशनल कीमोथेरेपीज. बट अब जो प्रेजेंट है, since we all know that genetics are playing a vital role, and we have a lot of immunotherapies in other cancers also. So similarly, we have drugs or therapies which are replacing a lot of medicines which used to, you know it. Next slide. Next slide. The present. So next slide. Recent advances in molecular biology, including the Human Genome Project, have allowed for the introduction of targeted therapies for the cancer. Next. Yeah. So there are many drugs which are introduced in head and neck cancer, which are known as immunotherapies, or which are known as targeted treatment, which are known as monoclonal antibodies, out of which one is trastuzumab. This drug was basically introduced for the breast cancer. So similarly, it is type of one of the tyrosine kinase receptors. It is composed of an extracellular ligand, binding domain, a transmembrane segment, and intracellular protein kinase domain. The tyrosine kinase receptor, when activated, stimulates many intracellular signal pathways, especially MAPK pathways or PI3K pathway. Through these pathways, the EGFR receptor stimulates cell growth, division, differentiation, migration, addition, and angiogenic activity. HER2 overexpressed in about 20 to 25% of cases of invasive breast cancer, and it is associated with increased risk of chemotherapy resistance, metastasis, relapse, death in these patients. So practically, this drug was introduced for breast cancer, but now we are using this drug in head and neck cancer. Next slide, please. So this is how you can see that this is a receptor, which is, you can see on your right hand side, that this is a receptor which is known as tyrosine kinase receptor, which is seen in all the cell membranes of human cells, and we target this cell membrane. Next slide. So this is a pictorial diagram. You can see that the drug, it binds on this tyrosine kinase receptor, or which is known as HER2 receptor, or tyrosine kinase receptor, and henceforth it doesn't allow the downhill cell machinery to act. Henceforth, the downhill signaling pathway gets retarded. Henceforth, it's able to stop the cell growth, which is a basic hallmark of cancer cells. So whenever you find across these drugs, once they bind to the targeted agent, so they halt the down signaling pathway, which in turn doesn't allow the DNA to get replicate, which doesn't allow cell to get divided, and so on. The cells get with the apoptosis and they die down. So this is the basic of the use of the EGFR inhibitors or the target agents. Next slide, please. So this is what I told you, trastuzumab. So this was a drug which was approved in 1998. It was basically approved for breast cancer. Still, it is approved for breast cancer, but now it is also approved for the head and neck cancer. Next slide, please. So coming to the EGFR receptors in head and neck cancer, how frequent they are, and how much beneficial these drugs are once they are used. So almost it is upregulated 92% of head and neck squamous cell carcinomas. EGFR levels increase in advanced tumors and in poorly differentiated tumors. Increased EGFR correlates with the poorer clinical outcome. So that means नटशेल में अगर मैं आपको समझाऊं कि जितना EGFR अपरेगुलेट होगा, उतना ज्यादा ट्यूमर तेज डिवाइड होगा, उतनी ज्यादा ग्रोथ ट्यूमर की ज्यादा होगी. Henceforth, the best side is that अगर ये ड्रग्स हम यूज करते हैं तो ये उतना ही बेनिफिट भी देंगे. So almost catch point is that it is almost regulated in 92% of cases. It is upregulated. So that means you have a chance to use in almost every patient of head and neck cancer. Next slide, please. So you can see that this is what I told you, that there are downhill pathways, mTOR, MEK pathways, PI3K pathway. So these are the pathway signals. Once obstructed from the extracellular domain, the downhill cell machinery gets affected and cell cycle division stops. Next slide, please. So second drug which is approved for head and neck cancer is known as cetuximab, or it's basically known as Erbitux. It is a recombinant monoclonal antibody which binds to the extracellular domain of EGFR receptor with high affinity, blocks activation of tyrosine kinase by EGF or TGF alpha, induces antibody hormone dimerization and destruction. So this is the mechanism of action of this drug, which is known as cetuximab. The COG trial basically first carried out in 2005, enrolled about 117 patients, randomized versus cetuximab, and primary objective of this trial was response rate. So you can see very well that response rate increased from 10% to 26%. However, primary endpoint of disease-free survival didn't the statistical significance. That means the difference was not to that extent that it should assume a statistical significance. And for cutaneous toxicity correlated with efficacy. So in these drugs, if you get a lot of rash or if you get diarrhea, this is a clinical indicator that this drug is going to act. Similarly, Trigo had a trial in 2004 about 103 patients who progressed on first-line platinum. Overall response rate was 13% with 5 complete responses. That means almost you can say 40% CR rates. Harari had a similar trial with 422 patients with locally advanced head and neck cancer randomized to chemo or chemotherapy plus cetuximab. So you can see a vast difference in 3-year survival, that is 57% versus 44%. Similarly, there was a good local regional control of about 56% versus 48%. Her drugs, which is used in head and neck cancer, are oral small tyrosine kinase inhibitors. They are oral drugs by the name of gefitinib and erlotinib. They are low molecular weight tyrosine kinase inhibitors which compete with the ATP binding site to the intracellular portion. So initial drugs were extracellular domain drugs which were binding to the extracellular domain. These drugs, they go inside the cell, they compete with the ATP binding site of intracellular portion of EGFR blocking phosphorylation, therefore activation of downstream signal pathways. Erlotinib was approved in US for non-small cell lung cancer initially, and similarly gefitinib was approved in Japan for lung cancer. Initially, these drugs were approved for the lung cancer patient, but now they stand approved for the head and neck cancers also. Next slide. So more studies in non-small cell cancer which were refractory to conventional chemotherapy, and we secured a response rate to the tune of about 20%. So similar, you have studies in head and neck cancer, gefitinib phase 2 trial of about 47 patients showing a response of about 10.6%, and cutaneous toxicity correlated with efficacy. And second drug, erlotinib, a phase 2 trial of about 115 patients shows us a response rate of about 4% only. Not very great response, but you have to understand that these drugs usually stabilize or halt the cell progression. They are not the drugs which are going to kill the cells. Coming to the future. So future drugs are bevacizumab, which is known as Avastin. So this is a VEGF. This is a VEGF inhibitor. One of the most potent promoters of angiogenesis is a VEGF factor, and it has been identified as a fundamental regulator of tumor neovascularization. They are overexpressed in head and neck cancer, indicates poor response to chemotherapy and high levels of VEGF induced by chemotherapy. Bevacizumab or Avastin, it's a recombinant humanized monoclonal antibody which binds and to neutralize the VEGF. And more than 30 clinical trials has shown a good response in the head and neck cancer. And phase 2 study has been in progress, which combines VEGF with tinib. So we are combining two classes of drugs. One is VEGF inhibitor, second is a tyrosine kinase inhibitor. So next slide. So another point of interest in coming time would be EPCAMs. So epithelial cell adhesions and activating molecules overexpressed in large variety of adenocarcinoma and small cell lung cancer, protects tumors from self-proteolysis and displays proliferative signal activity. Overexpression correlates with a negative prognosis. And another drug is which is developed is basically proxinine, which is anti-EPCAM antibody fused to subunit of bacterial pseudomonas and endotoxin. And after IPCAM binding endocytosis, endotoxin is cleaved and inhibits protein synthesis and lead to cell death. Phase 1 and 2 trials about showed a very robust response of about 88% and median survival of about 301 days versus 125 days in other patients. So trials are in progress, and novel IPCAM immune toxin is in development, which selectively cleaved by the tumor cells. So IPCAM is one of the molecule on which either we are tagging antibodies or we are tagging the toxins. And you can see that it has a very robust response rate of about 88%. So it's a very promising future molecule. Next slide, please.